Hello and welcome to Clinical Audit Awareness Week 25. So we're kicking off NQICAN series of daily lunch and learns with today's topic on patient safety and how we can effectively utilise clinical audit to prevent avoidable harm. So my name is Vicky Patel, Chair of NQICAN, Clinical Effectiveness Manager at the Rotherham NHS Foundation Trust and your Chair for today's Lunch and Learn. Little bit of housekeeping, the event will be recorded. It would be lovely to see your cameras on, but obviously if you don't want to be recorded, feel free to turn your cameras off. You'll note that your mics have been muted. You will be unmuted throughout the event at the point that we move to questions should you raise your hand and you've got a question to ask. The Q&A function is actually live as well, so please do also utilise this to post your questions or add any comments that are relevant to today's Lunch and Learn. So next slide, please. So 12:30 till 1:45 p.m. daily this week, NQICAN is running Lunch and Learns in collaboration with HQIP as part of Clinical Audit Awareness Week 25. You can register via the links on the NQICAN Future NHS Workspace or the HQIP web pages. Today's topic then, just to confirm, is on patient safety. It remains a really important domain of quality alongside effective, patient-centred, timeliness, equity and efficiency. And our topics throughout the whole week reflect all of these domains, and we hope that actually that you're going to join us at the other events that we're holding throughout the week. So next slide, please. So today's agenda then. So we'll start shortly with a recap on Clinical Audit Awareness Week and reflecting also on last year's key takeaways to set where your thoughts are at as we start to focus on today's topic on patient safety. We will hear from our key speaker on key information and points that we need to be aware of and considering when we're commissioning or providing health and care, and in particular information that we need to take into account when we're planning how we actually measure the impact of delivering clinically effective care, whilst also ensuring that we're preventing avoidable harm and that impact on health outcomes. And there will be the opportunity to ask questions throughout. You're going to hear the announcement of the Patient Safety Clinical Audit Hero Award winner, and they're going to present their winning project to us today. Now, before we close at 1:45, we're going to ask you to join in with an interactive evaluation on screen. We do value your feedback on the Lunch and Learns, and we do use this information to review how we plan and deliver future events. And finally, we're going to challenge you all. We want you to take away a challenge today for yourself to take forward in your own organisation. So next slide then, please, Louise. Here we go. So last year, we asked you all to be bold and ambitious. And this year, we really still want you to be bold and ambitious, but we also want you now to be starting to make those informed decisions that add value and impact. So Lord Darcy's review of the NHS that was published last year, it provides that opportunity to reshape health and care. We're awaiting the 10-year health plan, which we're expecting in a few weeks. We've got the new model ICB blueprint, and we've also got lots of collaboratives that are popping up left, right and centre. So we're all looking to deliver a more integrated and community-focused healthcare system. There's lots of publications on a daily basis that are coming out in forms of blogs, newsletters, social media posts with viewpoints. But actually thinking this week and today, are we actually then seeing that fine detail as yet on what this means then for clinical audit? So one of the clear messages within Lord Darcy's review was that shift from activity to outcomes and impact. So regardless of how many procedures you might do, when you do that procedure, does it actually make that difference on patients' outcomes and quality of life? And as our community knows, measuring outcomes and impact, it's that core principle of effective clinical audit. So further key points that he made were around data-driven improvements, that transparent reporting of outcomes, tackling that variation in care, having that focus on the workforce and culture, but also that focus on the systems, those integrated care systems, those audits that should really span across primary, secondary and community care to reflect that full patient journey. And then also utilising those patient-centred metrics. So thinking about the week again then, we're aiming to bring you something every day that which will help inform what we need to be taking forward in our own organisations every day, really, to deliver that effective health and care service that is safe. It involves people in their care and decisions. It's addressing that equity and that access, and actually it can be delivered with the current resource. So it's about using what we've already got differently, and it's supporting people to live well for longer. So again, just re-emphasising here, that's why we've kept these five topics, because they still remain as important. So having thought about reflecting on what this means for clinical audit, then what's it mean then for patient safety then today? So it's that continued focus on measurement to keep our patients safe, and that will contribute to all of the quality domains, that health and care's ambition, and really start to add that value and impact on health outcomes for all. So next slide, please. So just wanted to touch then, because obviously one of the key messages was about using what we've already got differently. So from that clinical audit perspective then, what have we actually already got in place that we could perhaps use more effectively to have more value and impact? So I've just pulled out a few of the national clinical audits here, and it doesn't matter what type of health and care organisation that you work in, we've all got national clinical audits that are applicable to us. So in the interest of time, I might just pick on a couple here. So the National Emergency Laparotomy Audit then, it focuses on those outcomes, that 30-day mortality. It looks to address variations in care, and it provides that real-time data and feedback. So it's really supporting that transparency, that benchmarking, and that safer surgical care. It's a high-risk procedure, and it's looking to make those improvements in survival rates and consistency of care to prevent that avoidable harm. So it aligns really nicely to patient safety here today. Another good one to pick out is the pulmonary rehab audit here, because this is demonstrating the value of that preventative community-based care, which again has come across in the review around that shift to moving care out of hospitals and into the community. So the pulmonary rehab one's a really good example. It's delivered in those community settings. It reduces hospital admissions, emergency visits, and primary care appointments. It improves that self-management, that physical activity, and that quality life for people with those chronic lung conditions. So it aligns directly really with Darcy's call to rebalance the NHS resources towards preventative and that community-based services. So from that patient safety perspective, that's about reducing those hospital admissions, it's improving the quality of life, and where it identifies that gaps in service that could lead to deterioration or preventable harm, that we're actually then putting those improvements in place to prevent that. It supports that safe transition from hospital to community. So again, we've got some good national clinical audits that are in place to help us focus on patient safety, preventing avoidable harm. But actually, can we pause and reflect this week to think about actually our participation in them? Is it effective enough then? Can we do more to actually then utilise the outputs to take it across our system with our system partners to really make that shift? So if we move to the next slide, then we can just have a quick look at that local focus of what's on our audit programmes. And again, in the interests of time here today, maybe sepsis, pulling sepsis out here, that focus on that early intervention and timely care. We're all measuring sepsis in our organisations. We're using that real-time data to reduce that variation in sepsis recognition and treatment. So we want to improve our compliance with sepsis bundles to reduce that mortality, aligns directly with patient safety. Another good one's the patient involvement and discharge planning. It's emphasising that patient voice and shared decision making, which again is coming across really strongly in the review of the NHS, and it's measuring how often patients are actually involved in planning their discharge. Focus on reducing readmissions, because we don't want to have failed discharges. It's improving that patient satisfaction with involving them in that decision making. And in terms of patient safety, it's that reduction in complications. So classically on discharge, a reduction in those medication errors, so it aligns directly with patient safety. So again, it's that same question to everybody: how effectively are we using the outcomes of the audits to drive those evidence-based improvements that will help us to avoid that preventable harm? So next slide, please. So opportunity here, I think, to pause and reflect on some of your takeaway messages from last year. So this is what the colleagues that joined us on the Patient Safety Lunch and Learn told us last year post-event. And we'll be asking you again at the end of this session for your key takeaway points as well. But whilst you just have a moment to read those on screen, just to recap on the takeaway challenges we gave you last year, which was around going away and checking if your strategies, your policies and procedures aligned with your patient safety work streams in your organisation, whether your programmes of audit consisted of audits in response to patient safety concerns, and whether those findings and action plans were taken forward with that focus on that preventable harm. Did you go away and strengthen that collaboration with your patient safety team so you got that shared purpose and delivery that adds that value and impact? And did you engage with your peers in your organisation who are supporting your organisation's model for continuous improvement, because collaboratively you can work together to prevent that avoidable harm? And then finally, that bringing in that PPI element to that measurement in response to learning from patient safety, and closing the loop with audit to evidence that impact of measurement and showing learning and improvement. So we set you quite a few challenges last year, so it'll just be interesting to see how you've got on, and we're going to stretch you a little bit more today. So next slide please, Louise, then. And then I'm going to hand over to HQIP for a few words. So considerations for clinical audit then today, then, as we start to receive this information shared by our speakers, really, it's the focus is on utilising clinical audit to prevent avoidable harm. We all know that actually we measure evidence-based care, we identify those shortfalls, and we help to drive that evidence-based improvement, whether that's in response to an actual patient safety concern, risk, or part of our mandated programme where we're participating already. So we want you to consider each day's topics every day, because they're all interlinked. So although we're focusing on patient safety today, we ask you to also think about the topics we're covering in the rest of the week when we're trying to participate in clinical audit to really prevent that avoidable harm, because they're all interlinked. So consider that value and impact. And then finally here, we've just put up some examples of the impact that clinical audit can have when it's utilised to measure and prevent avoidable harm. So I'm really pleased now to hand over to Tina Strack, Associate Director at HQIP, who's going to spend a few minutes talking to you about Clinical Audit Awareness Week from HQIP's perspective. So I'll hand over to you, Tina.
Thanks, Vicky. That was great. I always love hearing from you. Can I just say a big welcome from HQIP, aka, for those of you who don't know us, the Healthcare Quality Improvement Partnership. Big thanks for joining today's session. It's great to see so many people joining us. It's amazing. It's a good start to the Clinical Audit Awareness Week. As Vicky said, I'm Tina Strack. I've worked at HQIP for quite a few years. I was part of the judging panel for this award, and I have to say the caliber of entries was absolutely fantastic, and it was amazing to see the work that's going on the front line. I wanted to give you a quick overview of how HQIP is making a difference in patient safety across the NHS. Our aim recently has really been about trying to move from maybe a slightly old-fashioned view of audits of just collecting data to truly improving care. So HQIP we manage and commission about 40 national projects on behalf of NHS England, Wales, and several other devolved nations. These projects cover everything from surgery to end-of-life care, from the care of neonates to the cardiovascular program that Vicky mentioned. These projects help to identify risk, promote best practice through benchmarking, and giving healthcare providers the tools that you need to take action. I'm a little short on time, so I think I was going to give some examples, but Vicky's actually given even better ones. So I'm going to skip that little bit and just say that, we've really tried to focus the audits on making data available to the front line in as real time as possible, and making quality improvement resources and insights available. Now, I think if you're going to talk about patient safety, I do want to also focus on the clinical outcome review programs, formerly known as confidential inquiries. So HQIP inherited these from the National Patient Safety Agency in 2012. Now, I'm very biased because I've had the pleasure of working with all of these projects at some point during my 10 years at HQIP, and I think they're fantastic. The outcome review programs they're really rooted in patient safety, and they're programs that are designed to assess the quality and safety of health services, really trying to understand those pathways, those causal pathways to serious morbidity and death, identifying any remedial factors and opportunities for prevention. And I think they complement the audit so nicely because they dig a little bit deeper into the why something is happening. One of the projects that I currently work on is the Maternal Newborn Infant Clinical Outcome Review Program. Most of you will probably know it as Embrace. And one of the things they do is a case note review of all the maternal deaths as part of its mandate. And some of their findings in the past have been really, Vicky was echoing them when she talked about sepsis, failures to act on abnormal observations, inconsistencies in the use of early warning charts, and variability in thresholds for escalation and what triggers a clinical response. Now, as a result of this, we've got a maternal early obstetric warning score. This has been updated based on the evidence from the maternal newborn program, and that has improved the timely escalation of care, which is especially for conditions like sepsis, cardiac disease, and preeclampsia. And that program's work has also informed national reviews like the Ockenden report that was Shrewsbury and Telford Hospital, and the Reading the Signals report, which reviewed maternity services in East Kent. So these programs are well embedded and they're really in the system. So I think, the aim of HQIP's work is it's fewer avoidable deaths, more consistent safety standards, and national policies rooted in real data and experience. And our aims are the same as the patient safety aims, shifting culture towards transparency, learning, and continuous improvement. So thanks again for coming, everybody. Looking forward to a great week, and I'll hand it back to Vicky. Thanks.
Thank you, Tina. So really pleased then now to welcome Hester Wain back to join us all this week. Hester is Head of Patient Safety Policy at NHS England and here with us all today to celebrate how clinical audit can help to prevent that avoidable harm and share information with us that we all need to take back to our own organisations to take forward within our clinical audit and wider QI work stream. So I'm just going to hand straight over to you then, Hester.
Hello and good afternoon, everyone. So my name's Hester. My pronouns are she and her. Today I'm going to talk about something that's, as I'm concerned, the patient safety healthcare inequalities reduction and the framework that we have put in place around that. So next slide, please. So as you're aware, the 2019 NHS Patient Safety Strategy was published, and in that we made a commitment to patient safety healthcare inequalities reduction. Now, this commitment is there, you can see it in black and white, but actually it needed to be finessed. It needed to have real information and evidence underpinning it so that we could really start to understand what was needed in relation to patient safety and reducing healthcare inequalities. Next slide, please. Now, I'm not going to go through every part of this slide, but it's just to emphasise that inequalities affect many people, especially those with protected characteristics, of which there are 9, and those defined as, for example, part of inclusion health groups. So here is a very non-exhaustive list of those marginalised communities of people who suffer from social exclusion via, for example, poverty and insecurity. They are people who may be more likely to have experienced negative effects such as violence or discrimination, and those who have poor access or experience of healthcare and other public services, ultimately for them leading to poor health outcomes. Next slide, please. So why does this matter? There are significant impacts on healthcare for those in marginalised communities, which are wider than the direct impact on those affected. In fact, most obviously, people's own health outcomes are affected, but also if they're unable to access healthcare easily, perhaps due to challenges with, for example, digital interfaces, this creates more problems and then starts to reveal injustices in the system that lead to further mistrust as communities recognise that people who are patients may find it harder to make their voice heard and may experience discrimination. So there are lots of sort of loops and circles that are reinforcing all the things that we don't want to be reinforced and adding to those inequalities. And ultimately, this also has a financial impact. So when people don't feel equally included in or offered healthcare opportunities, their health will be impacted. And ultimately, that will cost more in the end for everybody because it will cost more to the system to address, for example, late diagnoses. So we know this has a knock-on effect in public health, for example, and it can be seen particularly in screening programs. So we know there's been research that found in England, cancer stigma is linked to lower screening uptake and therefore is more common among people from minority ethnic backgrounds. So we know some of these facts. Next slide, please. But what does it mean in reality? So these are examples from audits in most cases. So we know that in reality, Black women are nearly 4 times more likely to die than white women giving birth. That's horrendous. We know that 80% of trans and non-binary people who free birthed were not confident to access maternity services if they needed to. That would add to their risk of patient safety and harm from that. We know that Black children are 10 times more likely to be referred to CAMHS via social services rather than via their GP in comparison to white children. And we also know that 67% of sign language users have been denied professional communication support at some point in their healthcare journey. These are things that we already know and things that we need to start to deal with. Next slide, please. So when we talk about patient safety, healthcare inequalities reduction, we realised we needed to clarify what we meant by that with a definition. And specifically here, if you focus on the blue writing at the bottom. So healthcare inequalities include unequal access, experiences and outcomes within health and care systems. And when these inequalities cause harm or increase the risk of harm to patients, they are patient safety healthcare inequalities. As you might imagine, working in patient safety, I often hear that everything's patient safety. So we just needed to have a really clear definition on what we meant by that. So just recently, just last month, we published the Patient Safety Healthcare Inequalities Reduction Framework. Next slide, please. So this outlines 5 key principles that we need to address to reduce patient safety healthcare inequalities. So that first principle around communication is actually being really clear. All staff, patients, service users, families and carers have access to information and translation and interpretation services when needed. That's what we're really thinking about as a seriously underpinning principle, the first principle there. For principle 2, we're talking about training and we're thinking actually it's for all healthcare staff that receive undergraduate, ongoing and further training and accessible resources that improves all of our awareness and understanding of healthcare inequalities and risks associated with that. Looking at number 3, it's really important that we have accurate and complete diversity data for all aspects of healthcare. And again, in the clinical audit scenario, that's something very much that can underpin some of the work that you do and helps us to then understand better where those inequalities might exist, and then we can start to address them. Principle 4 is about co-design and working with communities, groups, people and patients in order to work out how things can work best in different spaces and using the knowledge and experience of patients, service users, carers, families, communities and staff. And then principle 5 there is all about research and how we can make sure that some of the research that's going on is actually also looking and ensuring that we understand where there may be inequalities within those spaces. Next slide, please. So within inequalities, within the framework, we have a number of patient stories. And we know that when considering diversity, we need to understand intersectionality to ensure that we learn and consider individuals and their stories to really comprehend how we can start to improve diversity and address inequalities. So it's really, really important for us that these people have shared their amazing stories. They have been so brave to come forward. And the most important aspect of this framework for us is those experiences that have informed it and those personal stories. They're all available online. They're part of the framework. And it's been really valuable to us to think about who is affected and how they're affected in a way that does not sit solely within, for example, one protected characteristic, but actually looking at people and as entities in a whole. Next slide, please. So Reducing patient safety healthcare inequalities may feel like an additional ask in an already stretched environment. However, there are some really significant benefits to these relatively small changes that are intended to reduce rather than increase workload. These benefits will affect patients, staff, organisations and systems. And so we've presented here those focused specifically around patients and families and those focused on staff. And if we can start to understand where those inequalities gaps are and address them, we can start to address it for everybody. If we make sure that as much of our information as possible is accessible to people with, for example, learning disabilities, it will be accessible to everyone because we will all understand it. So it's about really looking at that in different perspectives and thinking, how can we shift the dial and how can we make a difference on this? Next slide, please. So, particularly within the Patient Safety Healthcare Inequalities Reduction Framework, the importance of co-design with patients and communities cannot be overemphasised. Two of our patient safety partners, who you can see here, Priscilla and Khadija, have been involved in this work from the start. I want to take this opportunity to both formally recognise their contributions and to demonstrate to you the immense value of their input into this work. So these aren't two people sitting on a group who may be representative. These are two people who have directly contributed, absolutely challenged us to think about things differently, ensured that we consider all the different ways that people will see this framework, will understand this framework, really challenged us on what kind of patient stories are we including? Are they relevant? Are they relevant to all? Are we making sure that we're proportional in those stories? Are we making sure that we're not just bringing in stories of those people we have heard of? And are there other stories within that space? And then also helping to review and validate that framework that we've brought together and to really make sure that it's as meaningful as possible to everybody. So they are and have been absolutely amazing with this and continue to be amazing. Next slide, please. So I have some challenges for you, what you can do to reduce inequalities. So the recommendations shown here reflect ideas and actions from within the 5 principles of the framework, underpinned by inclusion and key aims of the patient safety strategy. So thinking insight, involvement and improvement. They're areas that you can all consider addressing within your teams and organisations. And one of the key things with equality, diversity and inclusion is that every little bit helps, and making small changes starts the shift towards more inclusion and equity for those. For example, here, we know that poor data quality makes it harder for the NHS to understand who's being left behind and why. It's essential for carrying out effective service planning, quality, patient safety improvement and monitoring. And when data isn't complete or isn't consistent, it limits our ability to fully understand people's experiences and needs. And then it can hold us back from tackling some of those inequalities effectively. Where the quality of diversity data within the data sets varies, this can also cause challenges. And it might be that we don't fully understand who are missing, and have we got all of those communities, and are we addressing all of those communities? And maybe those that are missing actually will be facing the greatest inequalities in terms of access, experience and outcomes. So it's really important that we start to bring this together and understand what those opportunities might be and how we can start to shift the dial. Next slide, please. Oops, can we go back one? Sorry. Yes, so thinking about how you might start to do this is looking at your local population. So firstly, understanding the local population is really quite key. And it's just a list of key contacts that might be relevant for you to help start to address the gap and to start really understanding how you might go about doing some of this. Next slide, please. So particularly like to thank all of those who've been involved in creating the framework, bringing the framework together. As you can see, we've got HQIP and NCPOD in there and NICE. So lots of organisations highly relevant to all of you. So thank you very much for listening, and I'll take any questions.
Lovely, thank you, Hester. So not seeing any questions in Q&A as yet, so have we got anybody who's got their hands raised? Lots of applause coming from the audience there, Hester. Fantastic. So Lisa, shall we unmute Lisa so she can post her question, please, Louise, if that's okay?
Yep, I've allowed mic, so if you wanted to unmute yourself, Lisa.
There we go. Hi there. Hi, Lisa O'Dwyer from AVMA. I put a question in the chat actually, and it was about your principle 3, the accurate and complete diversity data. Sort of interested in the strategies that you're using to capture that, because in practice we find that, you know, it is quite difficult. You're reliant on participation for that, and while some patients will willingly engage, many don't. So capturing accurate data around that can be quite challenging, and I wondered what you were doing to address that.
So absolutely. So the first thing we're looking at is really thinking about at what points in time we capture that data, so that we're not going back and asking patients the same question over and over. We're looking at how, for example, might patients be able to update their own information through, for example, the NHS app. And we're also looking particularly at how we can help staff to be able to ask questions appropriately, sensitively, and clearly, so that the data that we ultimately get through those processes are correct and balanced. And absolutely, it's everybody's choice as to whether they choose to give that information or not. But if we're not enabling people to have that choice, then we're not making the offer good enough for the NHS in reality.
Thank you.
Lovely, thank you. Okay, I'm just going to refresh my Q&A there just to see if we've got anything else that's been posted. No more questions in the Q&A at the moment. Has anybody else got any more questions for Hester, if you want to raise your arms? For me, it's really timely, Hester, this. It's brilliant because it's coinciding now with us moving forward Clinical Audit Awareness Week, obviously, and it's just allowing us to have that moment in time to pause and reflect and start to think about where we need to be. And then obviously that 10-year health plan's due out in a couple of weeks as well, so it's a good opportunity for us back in our own organisations to start to think, right, what actions can we specifically take now to start to work differently. So yeah, it's really good timing. You've got the links that are in the slides that are being shared with the audience. Is it on any of the future workspaces as well? Is it on the Health Inequalities workspace and patient safety, or has it got a space of its own?
So the framework is sitting in the NHS England web pages that are accessible to everybody. I've posted the link into the Q&A session so that people can go there directly. It isn't actually sitting on futures because it's out there in the wider public domain. So it actually sits within the Healthcare Inequalities programme as the actual space it sits in, but it's linked directly from the patient safety part of the NHS England website as well.
Thank you. I just think it would be great as we go forward, wouldn't it, from a clinical audit perspective, if we can be starting to capture and share between us all how we're actually now starting to factor the framework into our work, so that we're helping to support the agenda and helping to prevent that avoidable harm. Thank you. Okay, so I think if we're not seeing any more questions, we're not seeing any more hands at this moment in time, then I think we'll move on to the next slide then, please. Back to you, Hester.
Excellent, thank you. So I'm very privileged to be able to announce the Clinical Audit Hero winners. Though we're going to start a little in reverse order, so we're actually going to start with runner-up. I'd like to do a drum roll, but I don't know how to do that on this, so we'll just move to the next slide. Excellent. So we've got, oh, I can't see the picture. Oh, it's come up. Fantastic. Right. So this is Mossab, and the judges' comments on this have been really impressive. The project was an important clinical area, showing good improvement, and the judges were really glad to see the co-production. It's a very useful and simple tool, and the judges very much like the sharing of resources for vulnerable patients and the increase in coping strategies. So very well done there as a runner-up. Fantastic. Right, and that's all come through properly now. Yes, it has. All right, so next slide, please. Okay, so the other runner-ups, we had 2 runners-up in this category, was Swasti and Sabasari. I very much apologise if I've mispronounced your names, and Pradumna. And Claire. So a great team there by the sounds of it. And the project was really well articulated with a compelling problem, good communication and good systems working. The work within the ambulance service has had a really interesting impact. So well done to all of you. And finally, but not least in any way, shape or form, we'd like to move on to the winner. So the winner here is Sarah, and the judges' comments were it was a really well-written project with clear indication as to why you did the project, and the importance to an involvement with parents was really very, very strong. Regular and rapid audit feedback cycles, so that sounds really good, and assurance of mental health and anxiety. They liked that it wasn't a one-off and that you talked about the 9-month audit shift. It was also easy to understand from a patient point of view and had strong cross-trust working with an SLA. So Sarah, very well done. And I believe we'll now be moving on to you giving your presentation.
Yes, thank you very much. I think you've got my slides there, and like you've just introduced, Hester, I will talk very briefly through the project and the process and some of the tools I used while implementing this audit. So next slide, please. So just to very briefly set the scene for those of you not in a neonatal speciality, at the time of this project, it was a brand new role in a special care baby unit that had never had any therapy input before. They were very happy to realign some of their funding from a nursing vacancy to advertise for a developmental therapist that could be an OT or a physio, in line with some kind of national recommendations about the need for therapists. But it was also worth recognising that actually the national recommendations would advise that a unit like this and all units across the country ideally need both an OT and a physio. And there are areas where we overlap, but there are things that we have unique specialisms within. So it was very clear from the outset that audit was going to have to be a big part of this role to demonstrate the impact, but also the sustained gaps and where a wider team would continue to add worth and focus on prevention of long-term deficits for our neonatal populations. So if we can move on to the next slide. Did use a number of QI tools throughout this. First and foremost was a pestle analysis to really consider the external pressures and the context in which I was going into this post. Needs to be kind of recognised that a weakness at this point was I largely completed this by myself, and for this to be most effective, it is something that is ideally done as a group to help form your overall plan in considering that bigger picture. But as you can see in some of those economic factors, the post was isolated. It was kind of undefined at the outset, and there was limited comparisons of successful models to look to. So although I recognise this as a weakness, this tool was still really valuable in helping define all of the factors that are underpinning that workforce measure. And I just wanted to draw your attention to some of those individual factors within that PEST analysis, again, to help kind of align the context of where I went from here. Lots of the speakers before me have already touched on lots of the political influences, the Ockenden reviews, the Darcy reports, and ultimately there is a real drive to increase therapy provision in neonatal care as a preventative health measure to promote lifelong health and minimise health inequalities that preterm infants experience when they're discharged from neonatal care. Obviously, Ockenden, in terms of maternal health, but also accessing an MDT focus that work and train together and have aligned principles. Obviously, very relevant to a service that has never had a therapist in there before, and how we learn to work together and move forward with the same outcomes and expectations. It's worth touching on as well in the social analysis. Medical advancement does mean our preterm babies are being born earlier, surviving at younger gestations with more complex health needs and more long-term needs across a health and social care system. And there is a real increased need, therefore, to start therapeutic intervention really early to improve those long-term outcomes and support families at the very beginning of that journey, but also to manage a care burden in other parts of the health, education and social care services. And that's something that obviously overlaps into that political analysis within the neonatal critical care review processes, which are quite well defined. They're several years old now, but significantly, it's also worth linking this to a growing area of research called the theory of moral injury. The theory of moral injury, which was defined quite clearly during COVID, but is increasingly being applied to a neonatal context, which is really about life-saving care can be traumatic, and it can be traumatic for the people delivering that care, because the things that you might need to do to an individual, but an infant, to keep them alive can be really distressing, especially when you need to consider what that their long-term outcomes might look like and what the cost of that life being saved might be for a family. But I also think in this context of being a new role, and a new profession coming into this space in this individual unit, that kind of theory of moral injury also applies, because to be kind of welcomed into that space also needed recognition that there was a gap, there was a need, and that I was there to change something, which could cause people to really reflect on their own practices and put them in quite a vulnerable space, which is something I really needed to be mindful of when I was going through these QI processes. If we could move on to the next slide, please. So with the pest analysis in mind, I did then bring some of those factors back to the team and think about what do they feel they would like me to do, and what felt kind of a good starting point. And ultimately, a lot of the staff identified that positioning was something they really clearly understood was a therapeutic role that could have immediate and long-term benefits. They felt it was something that that felt quite safe, that they knew they had a role in, but that they could refer to someone else as an expert in. And so from a change management perspective, it was quite a welcome and safe starting point. Staff were open to understanding it. They wanted to understand more. It was something they were happy for me to kind of benchline audit and think about where we could make improvements. And it's worth pointing out here that at the project's outset, monthly audits were showing that 100% of infants in this unit were needing major repositioning. And there's lots of consequences when positioning goes wrong for the family, but also for the immediate medical care. When a baby is not well supported or comfortable, their respiratory support is going to be higher. They're not going to sleep as well. They're going to burn more calories. They're going to need more medication. They're going to need more medical intervention. Never mind just the family perspective of feeling that their baby is comfortable and well cared for when they're not able to be there. So it kind of helped filter across the whole medical, nursing and family teams as something that was quite well understood and that they would like to look at a bit more with an expert in that area. So if we can move on to the next slide, please. So I did use a fishbone diagram to kind of break down some of the factors that were affecting current practice in this area. Something that I was really aware of when using this tool is it was really helpful to identify all the causes, not just the obvious ones, and that was going to be really helpful for planning the implementation and the changes. But it also is something that, because it identifies so many influences, can be really overwhelming, and it can it can almost dilute your starting point, especially when this was quite an isolated post, kind of being driven by an individual with lots of people who would want to support and influence in different areas. So as a result, I did use the fishbone alongside another QI tool with the PDSA model. So if we could move on to the next slide. So the purpose of the PDSA alongside the fishbone really allowed me and the rest of the team to focus on different elements of that fishbone within a Plan, Do, Study, Act cycle, being able to come back and review and, if appropriate, move on to another element of that fishbone skeleton. It was really about the implementation phase and evaluating what changes we're making. The audit tool that was used to measure the position of the infant was the same tool that was used to baseline measure. And so that really helped keep the consistency and effectiveness really clear. But the PDSI specifically helped with keeping the goal SMART with small changes. And that was really helpful for the rest of the team, because I could say, okay, this month we're really focusing on head positioning, or this month we're really focusing on making sure our equipment trolleys are up to date, so that when you need to make an emergency change to a positioning, you've got all the resources ready. And that really helped with kind of communication. And making sure everybody was on board with different elements of focus, but also the evaluation that happened at each stage of that. And it's important to recognise that PDSA cycle happened in various ways. Some PDSA cycle happened maybe within a week, where there was quick wins, and some overlapped into other cycles that ran much longer. And it took to the end of 8 months for a really demonstrable change, which made a shift from 100% of babies needing major repositioning to 100% of babies needing only minor repositioning. And that was a shift that really took until the first 6 months to notice any kind of significant statistical change. And what we refined as that was repeated and consistently managed was that more and more were needing minor repositioning, but also more and more were needing no repositioning at all, which was really positive to see that change. And I think those figures were reported back monthly, so when the rest of the team could see that not just were they happy and their practice and their confidence in these areas were changing, but the numbers were also demonstrating that as well. So if we could just touch on the next slide, which was my stakeholders. I think I did a lot of work on this one quite reflectively, but I think it's important to recognise from a QI point of view and an audit point of view, because it changed quite significantly whilst going through multiple PDSA cycles, mainly because my starting point was a lot of staff have never worked with a therapist before, so they don't know what they don't know. They didn't know what they need to ask. They didn't know what the best approach was for me to take in some of these things. So we had to do a bit of a trial and error. And we had a lot of people that moved between different sections in the stakeholder analysis. You know, I've talked about already, it was an isolated post, so a lot of the drive and the initiation needed to come from me. But we had a lot of buy-in from some of our more senior members of staff who had obviously helped create the post, who had helped support the recruitment. But actually that was to some degree quite removed to the people on the clinical floor who were thinking, well, how does this help me in my day-to-day if you're just going to ask me to do something totally different with equipment I don't have access to, or something I don't fully understand. So I really had to reflect on, especially in a nursing context, which is quite different from neonatal care, from a neonatal allied health professional, where actually your nursing shift changes every 12 hours versus I'm there multiple days a week. So I could have a really good day, a really good, efficient PDSA cycle, and then a totally different staff group might be on the next day, and they might fall within a more opponent or more resistant stakeholder group, which means my approach would need to be different in order to bring them along with me. So I do think this was really kind of important for me to reflect on, to make sure I didn't have any fatigue in moving this project forward, because things like if I had a week annual leave, sometimes I would come back and it was like the past 6 months hadn't been there, versus actually if I was able to have stakeholders who were really invested, not just bystanders. They helped carry some of those measures forward even when I wasn't there, so that it was a more sustained change, not just something that I came in and did and didn't happen when I was away. So I do think that's kind of an important reflection, because that also helped me target and identify the individuals who were maybe more open to further work, and who would therefore help influence the rest of the team at points where I was not going to be there for like a night shift, for example. So if I could just touch on the challenges on the next slide. I think it's important to not hide from the challenges. And I think, you know, on the surface, this could be quite a simple, you know, a simple change, just improve positioning and comfort. But hopefully the processes I've talked through and some of the context I've given you in terms of neonatal care and the pressures on neonatal care, not just in terms of workforce, but politically in a litigious society, that actually, you know, childhood disability is one of the biggest costs to the NHS long term. There's lots of vulnerabilities in neonatal care, and that's something that I had to wade quite delicately through. It's a highly respected specialism. People are very proud to work within that, and they make really huge, valuable influences on families and infants. And I wasn't there to take away from that. I was there to be part of the team and add to it. I wasn't the person to say nobody else can work on positioning, but that really filtered into the readiness of not just the unit, but the individuals and all of those stakeholders for their individual readiness to participate in some of those changes. Because very much so, I was an outsider in a role they'd never had before, that sits out of their nursing structures and their usual practices. So no matter how ready they were for change, there was a reality that was individual, and different people needed their own timescales and their own kind of introduction to the things I could bring to the table to help move that along. And I had to kind of constantly monitor and adjust my approach in that PDSI cycle based on who was on the unit from a staffing perspective, who was on the unit from a patient perspective, and what each of those groups needed. Time was also both a strength and a weakness really here, because I was on this unit 2 days a week, which ultimately isn't a lot, especially to overlap and engage with a nursing staff group who changed every 12 hours. But the other side of that was to families. I was quite a consistent presence, and so the families were a real group that I worked alongside to be a consistent face, to work through my PDSA cycles, to use them as key stakeholders in influencing the feedback they were given, and how I got different staff members and stakeholders to become more actively involved. Impatience for me definitely played a part, because 2 days a week isn't a lot, and it took a long time to actually have the numbers reflect some of the changes I was maybe seeing on quite a small scale, and change fatigue, saying the same message repeatedly, or feeling like I'd made good progress and then had to go on annual leave, or the staff group changed and my stakeholders were different, was challenging. And that was a real shift from actually, again, just an AHP generally context, where we have quite a consistent background in a lot of other specialisms. And the reality of just actually, I was an AHP that was in a whole team that never had one. So nobody really spoke my language. They don't necessarily understand the full breadth of what OT can do. And I was having to work more broadly to fill in some of those universal principles of a developmental therapist, not just an occupational therapist, so that I could manage the risk and provide the best service to these families and patients. But that kind of, from my own personal drivers and an occupational therapy point of view, was a challenge that I had to kind of keep myself in check for, and making sure I was doing the best for patients on the ground. And I touched on moral injury a bit already, but I kind of can't overestimate how significant this was, not just in my situation, but in neonatal care more widely, and the impact this had on the different approaches that needed to be aligned in this situation. You know, accepting my role and the advice I could bring was really an acknowledgement that even experienced staff didn't know some of these things, and that could cause them to reflect on the care they'd been given for years. And you know, my purpose there was never to make anybody feel that they hadn't been delivering the best care, but we really wanted to look together about actually how we could improve anything. And so if we move away from challenges and look a bit more about the outcomes, which is slightly nicer. So the positioning audit was completed monthly, and that positioning audit was something that's been used with all units in our network now. And so for like I've mentioned, the first 8 months, 100% of babies were needing major repositioning. But on month 9, that was the first month where all babies scored as needing only minor readjustments. And that has been maintained, and at different months has even improved, with no babies needing even minor readjustments. So I think the numbers finally caught up with what we were seeing on practice, which was really nice. And if we just move on, I've got some comments on feedback on the next slide, which was positive, that actually it was across both staff and parent groups. And as I said, parent and families were a focus within several of my PDSA cycles about making sure they were educated about the ways they could support their baby's comfort, because that was a support mechanism for staff as well, because staff coming on might not know that infant's individual preferences, but a parent will. And so it was nice to collect some objective feedback from both those groups to really recognise how things had changed throughout that process. And that is pretty much it. I've got a slide on the poster that was used to share some of the evaluation and the different tools. And I've got a slide with some references of some of the models and tools that I used throughout the process. But otherwise, I'm really happy to take any questions.
Lovely, thank you, Sarah. That was really insightful. Absolutely. We've got a question in the chat. Susan's popped in. I don't know if you want to. Did you want to ask it yourself, Susan? I'll just get Louise to unmute.
It might be easier if you raise your hand if you wanted to, so then I can find you quicker.
Yeah, I can't see it in the chat, so I can't
there you
jump
are.
in.
Right.
There you go.
I've allowed your mic now, Susan, if you wanted to unmute.
Hi. Yeah, no, I was just interested when you were reflecting on the cultural change, because when I've done a QI project before in previous roles, when I sat in NHS Lothian, I did a QI project, and that's the QI methodology is very process-led, and so one of the things you come up against is obviously the cultural change and the team dynamics that exist across maybe the different services that are involved in that particular patient's care plan. And you know, in previous roles that I've had, I needed to do some training in human factors and ergonomics, which I found laterally actually helped me because of that systems thinking. It addresses that side of the jigsaw, if you like, about looking at spending time looking at the team dynamic and the culture and who needs the buy-in to make those changes. And it is probably the biggest challenge that I found. I mean, it's quite some time since I did that project, but that was one of the big takeaways that I had, was that that actually almost like human factors and ergonomics in tandem with QI together make a powerful combination, because you get that insight into the team dynamics and culture side of things, which can mean that, you know, you were talking about, you know, if I wasn't there for a week, I was on holiday, or do you know what I mean? And I just wondered if that, yeah.
Yeah, I totally agree. And that was something I was really aware of, because just a neonatal context, there's a real shift on moving towards a more preventative healthcare model, embedding AHPs, starting these interventions early, not waiting until there's a problem to refer to an AHP, but actually having AHPs there at the standpoint. And I think because of that context, I was really aware of those human factors, and that was really going to be the biggest influence of my success. I didn't want to stick with a responsive model where I was coming in, you know, they would ask me to see a baby that they were already having trouble positioning. And that's where actually the fishbone was something that I used as a tool for me. It wasn't something that the team was ready for me to sit down and do together as a group, but it did help draw out some of those human factors that just really helped me hold them in mind as I moved through some of those PDSA cycles, because it is culturally was one of the biggest shifts that needs to happen, and it still is, I think, with every service and with every change, but specifically where this has grown really nicely, this service, into a cross-organisational, you know, SLA hosted outside of the acute trusts, but working across boundaries, and that's given us then some strength to come in to say, actually, well, we've demonstrated an outcome, our team has grown, but we're here as a not constrained by some of those organisational boundaries to say, this is something that works elsewhere, we can do it here, come along with us.
Yeah, an excellent piece of work. Thank you.
Thank you.
Powerful. Okay, couple of hands coming up. I realise we've got another question in the chat as well, but we'll just move to the hands then. Christian? Should be able to take yourself off mute to be able to ask your question. Lovely.
Thank you. Thank you. Hello, can you hear me?
Yeah,
we can.
Thank you. Thank you for a fantastic presentation. May I ask, how do you assess, how do you measure moral injury? And at what point in time did it start to tail off?
It's not something I could specifically measure. It was something else I was just really aware of. And one of my strategies was basically finding different ways to connect with staff that were not just about me solving a problem. So really becoming embedded in part of the unit. And I think that sounds really simple, but actually being part of the T-Rota, being part of actually, although I'm not employed with that trust because I was working through an SLA and I had different commitments, that actually being seen as part of that team, so that I also was part of that moral injury. I was also part of that. We all want to be doing the best for the families, and therefore let's look at it all together, was really was challenging. And I think once that trust was a bit built up, that really helped overcome some of that moral injury, and that helped then staff to see that this is a route of escalation, so that they didn't just have to hold that themselves. They could say, actually, I'm really struggling with this, can you help me, rather than feeling really quite vulnerable in that space. But I think that's also where that's quite an individual process. Obviously there is a unit culture and a service culture amongst that, but it's also quite based on an individual, and that can be different for that individual based on the patient they were looking after compared to a patient they had looked at after previously and maybe learned something from. I think it's just another thing that I was really aware of, holding in mind, and tried to create that safe space. So I really, as an OT, I'm trained in mental health and activity analysis and breaking down information in an accessible way. And so I really was applying that to each situation to try and mitigate those moral injuries and meet each individual and each patient where they were at, and adjust that. So it's not an easy win, and you won't always have kind of the quick answer to measure that, but those are some of the approaches I tried to use to hold that in the forefront of my mind when I was moving through this project. So I hope that's kind of given you an idea. It's not a specific answer, but some of the strategies that I tried to work with regards to moral injury.
I'm grateful. Thank you.
Sarah, thanks, Christian. Okay, Dorothy.
Hello, hi, thank you. I'm a patient safety partner for ULTH in Lincolnshire, and I'm previous ex-clinical as well. So I'm very impressed by your presentation, Sarah, so thank you for that. And just picking up on a point from Susan, who commented earlier, for me, when I've worked with the staff on the quality improvement projects that they've been working on, the human factor side, I was thinking as you were talking, you know, is that a consideration? Because there's a lot of information that you've presented there in how you were viewing it. And it was great to see that you'd consider the human factor as well, because the amount of people that you've had to adjust to do this project on shift changes, different levels of staff, the families, all of those difficulties and challenges that you've had, the human factor definitely comes within that. So thank you for highlighting that. My question will be, with regard to the measures here for any ongoing review of how, you know, your if your project is still on track and everyone is still buying in.
Yeah. So the service itself has changed. We've grown, we've more staff. We have expanded our service level agreements, so we now work across 3 neonatal units. So we've grown, I think we've more than tripled our COP base that we now serve. And so we continue to use the positioning audit, the same audit tool, in each of those 3 sites. And it's interesting because each of those 3 sites now have slightly different, they're at different stages. So George Eliot, where this project started, are probably slightly ahead of the other units which have only more recently had access to therapeutic support. But also, for example, one of the units we now cover has a higher level of acuity, which presents different elements of those fishbone challenges. So yes, it's still being run, it's still sustained, and also it's now a bit more measurable across the 3 units we work in, but also that audit tool is now used across a whole region, and so across, I think it's 18 units in the West Midlands. So it is then something that is being looked at and measured and implemented a bit more widely, so we can compare and also learn from each other, learn what it's worked in other units, so that we can apply that to really best support our infants and their families.
That's great, Sarah. I look forward to seeing it more widespread as well certainly within the trust I work within and everyone else's trust. Thank you so much.
Thank you.
It's brilliant. Thanks, Sarah. I think that was one of the points I put down, was that impact, the impact you have in far more widely. It's gone right across the region now, so it'd be brilliant to see that go even further, wouldn't it? Which is excellent. Thank you. And I'd got one question for you, Sarah. I know somebody's popped a question in the chat, which I was just going to put to HQIP in a minute, but words of encouragement then to others to enter their projects for future awards then. I just wondered if you might share a few words that might encourage others, because it's really valuable listening to your experiences and how we can pick this up and adapt it locally.
Well, I think other people have touched on it already. I think sometimes it's the human factors that are hard to define. And so we cling on to some of the QI models to try and formalize things. But actually, when we can really be truly reflective and put that whole piece of work together, I think that is really valuable. I mean, I was very lucky that it was one of my colleagues who's on the call, Addy, who put me forward for this, which I hugely appreciate. But I also think that process of reflection, even for myself as an individual, helps keep me accountable, keep me on track, that this is something that is still at the forefront of our practice, that it's not just me, it's a whole team, both of AHPs and across the units. And I think that's the whole process of change management and QI, isn't it? And making sure you don't burn out with that change fatigue. And this is just a nice example of showing actually how far we've come. And yes, there's still further to go, but it's a good reminder, and events like this are a good reminder to show the impact and the positives you have, which can really help drive further change.
That's brilliant, and thank you for submitting. And obviously you're very worthy winning team, but it's brilliant for us to be able to then hear about it so that we can then share it more widely as well. So that's fantastic, and it will be written up as a case study obviously with HQIP and published on their website. So thank you, that's brilliant. One really quick question then before we head to a quick evaluation and takeaway challenges then. Quick question for HQIP: will everybody that has submitted entries for the awards get feedback? Just a question in our Q&A.
Vicky, if I might be able to take this one. This is Lacey from HQIP. Yeah. I put the answer in, but our plan was not to send feedback to everyone. We were delighted with so many entries this year, but it was a mammoth task to shortlist and then judge. However, if anyone wants specific inquiries or specific feedback, then do email communications@hqip.org.uk. And then in addition to winners and runners-up, we will be delighted to publish case studies. So again, if anyone wants to make contact, if you weren't lucky this year, please don't be put off. The levels were incredibly high, but it doesn't mean that we wouldn't like to publish your case study. We would very much like to do so. So again, contact communications@hqip.org.uk.
Thanks, Lacey, and I think that's really, really important for the clinical audit and wider QI community as well, to see the other entries that were submitted, because like you said, it was high caliber, and actually we can learn something from every project that was shared. So it'd be really valuable for us as a community, I think, to be able to see that. Thank you. Okay, I think then we're on 1338, so I think we'll move on to the evaluation slides then, please, if that's okay. Lovely. So Louise has popped a QR code up here, so we'd love to hear from you. So if you can scan the QR code, the evaluation is going to be kept open for another week or so, isn't it, Louise? Just so that if you haven't had time to stay till the end, you can actually, we can prompt you to contribute to the evaluation. Your feedback is extremely valuable to us, and we do use it for future events, as we've said, to help to make sure that we tailor the information and the events to what the audience actually wants. So please do scan the QR code. I think Louise will load it up and share the screen so we can start to see some of the questions coming back in for you. So just bear with us. Lovely. Okay, so yep, the information and perspective on patient safety here so far then. So hopefully we'll get more of you answering and we can start to see these figures go up here. We do want to get the right level of information here. As we said at the start, our challenge for you all here today is to share more widely that information so that you can then pick that up and take that back to your organisations and your systems, so we can start to work together to move to that next level that we're all being challenged to do at the moment. Lovely. Brilliant. Okay. And then, yep, lovely. We've had Hester join us today, which has been a valuable experience again for us. It really does share us with the latest information, and obviously the Health Inequalities Patient Safety Toolkit that's published that we all now need to be picking up and taking back. So and obviously we've got the signposting. Would definitely urge you to head on over to the link that Hester's provided, and obviously we'll put the information out there for you post event as well, so that you can now start to access it and take it back to the individuals that need to know about this in your organisation and system, so we can start to be applying it and making that difference. So brilliant, this is good, and it looks like we're all learning something that we can use back in our own work, which is absolutely what the event's aimed to do for us. Lovely. Okay, and obviously now our winner of the Clinical Audit Hero Award and sharing the project and the learning for us all. This is good. And then some of your top takeaways then. Look at this. This is brilliant. So thank you for filling this in, and obviously we will make this available with the slide packs, and obviously we'll use it to shape our future events. But it is really worth looking at actually other people's top takeaways, because it just, again, it influences us back in our roles, back in our own organisations as well, if we've not perhaps thought about something somebody else has picked up on and had a slightly different focus. So this is really good. So thank you all of you for contributing. So like we say, we're going to leave this open for you then to continue to feed back on. So if you know that you've had colleagues that have had to leave the call early, there's the opportunity there for them to go on and add their thoughts and their perspectives for us. Lovely. Okay, conscious we've got about 4 minutes left, so Louise, we'll leave that open then, and if we could just move to our key takeaways really. So I think we've got a couple more slides literally for you all before we leave you for you to go away and enjoy the rest of your day. So if you're able to put the slide back up, it should be our takeaway challenges for you all. So fantastic. So value and impact is what we're pushing you for this year then. So it was just a quick takeaway. Obviously we've got the key messages from Hester and obviously Sarah's presentation as well, and Tina's shared some perspectives from HQIP. But it's really just, if you don't do anything else, as you're getting those requests coming in for the clinical audits to the clinical audit teams, or you're getting those ideas in clinical practice, it's about just taking 5 and asking yourself 5 questions really, and that's how this topic's going to really add value to your patient outcomes, how it's actually going to support preventing that avoidable harm, and thinking about your metrics then that you're going to use to evidence the impact. And if we're specifically here thinking about some patient safety metrics for us today, that reduction in adverse events, so actually your fewer medication errors, your falls, your pressure ulcers, your infections, patient outcome improvements around lower mortality, readmission, complication rates, that timeliness of care, those faster response times to deterioration or reduced delays in treatment, and obviously looking at some of your patient safety data around that increase in maybe near miss reporting, which is indicating that stronger safety culture, or a decrease even been any serious incidents? And then last two questions really around, is this topic going to measure that pathway across the system working with partners? And finally, how can we effectively utilise clinical audit to drive that healthier future? So next slide, please, and we'll just share with you what's happening for the rest of the week. So yeah, tomorrow is patient and public involvement. So thank you for joining us today. Schedule for the whole week. We've got some QR codes here. If you've not yet registered, please do scan the QR codes so that you can register for the event, or you can access the links via the NQICAN Future Workspace or the HQIP web pages. So I think we should then move on to a final roundup slide. Lovely, fantastic. So it's just joining that live Q&A event that HQIP are hosting between 2 and 2:30. It's signing up for tomorrow's Lunch and Learn, which we've already talked about. There's the opportunity to access wider resource. There's a video out here from Celia Ingram Clark, who is now the HQIP chair and clinical fellow, Ollie as well, Dr. Ollie Burton. And then obviously the patient safety case studies that are published as well on the website for you. So lots of sharing, lots of resources for you to access, and we're hoping that you'll join us for more events as we move through week. And then if we move to our final slide. Lovely. So it's just an absolute huge thank you to everybody that's joined us on the call. Really big thank you to Hester for joining us and giving us that update that we all need now to go away and access and take back to our own organisations. You've also given us some good key points to think about. Obviously, thank you to our Clinical Audit Hero winners, Sarah and her team, and obviously our runners-up and HQIP as well. Louise, you've done a fantastic job, and Carly behind the scenes as well in terms of preparing for the event and sharing today as well. So look forward to seeing you at our events for the rest of the week, and we also look forward to seeing you on your NQICAN Future Workspace, so you're sharing your local plans and what you've managed to make an impact with here this week. So take care, we'll see you at future events during the week, and have a lovely afternoon. Thank you.